Welcome to another week of Without Pain Wednesday, where we get together every week to talk about a different topic related to getting out of the back pain cycle for good. And this week's topic is pain. We're going to talk about some of the aspects of pain that are maybe not so well known, and the psychology side of pain, the side of pain where it's not so much a physical stimuli that causes the pain. And so this is a live stream. So if you have any questions at any point, feel free to post in the chat, which will be to your right if you're on a computer, or down below if you're on a mobile device. And let's get started. If you're here, let me know where you're watching from. My name is Dr. Ryan Peebles, and I've dedicated the last 20 years of my life to understanding and reversing the root causes of chronic lower back pain. And so I have a personal history of back pain that lasted over 10 years. And I've kind of gathered everything I've ever learned over these past 20 years and put it all into one program called Core Balance Training. And that's why I'm here. So now to help people like you if you have back pain. So we have a lot to get through today. This topic is quite interesting to me. I first started learning about this aspect of pain, the psychological side of pain, in physical therapy school. They teach it to healthcare professionals, but I feel that it's not taught enough to the general population. And so that'll be one of my goals today, is to just give you a better understanding of what pain is and the different factors that influence pain. So again, if you have any questions at all during the stream, go ahead and post in the chat. And I will get to the questions after a little presentation I give, and we're also going to watch a YouTube video. It'll be quite short, but very interesting, and hopefully you guys find it interesting as well. So let's get right into the first slide, and let's get this out of here. Okay. So the psychology of pain. And I will warn you, this topic could potentially be offensive. It could be interpreted as offensive. So I want to start out by saying I'm not trying to minimize the significance of pain. Pain is very real, and it is, even if it's influenced by psychological factors, it's still real. And you still feel it. So it does not minimize the significance or the impact that pain has. And I'm realizing again, I got to get my chat box out so I can see if anybody posts in the chat. All right, nothing yet. So pain is not just about the tissues of the body, tissues being anything physical of the body, right? Bone, ligament, tendon, muscle, anything that is a physical cell would be considered a tissue. And that's not the only thing that is what causes pain. Pain is actually completely created in the brain. It's an interpretation of signals that are sent from the cells of the body. And the design of pain is to protect you from potential harm or damage. And so it is the last thing that happens. It is the end result, as I talk about in the masterclass. And there are many factors that go into pain. So let's talk about some of those factors. The perception of pain is influenced by several, what they would say in the medical world, non-physiological factors. I'm calling them non-tissue factors because I don't know if physiological really makes a lot of sense to everyone. So non-cell or tissue factors. So personality, your thoughts, your beliefs, socio-cultural variables. Put a star next to learning. I think learning is one of the most significant, in my personal opinion, influences on the pain that we feel and emotional reactivity. So I'd like to start out today's kind of this presentation with this YouTube video. And my goal for this, what I'd like to accomplish with you is to just help give you a better understanding of where pain comes from and why and what could be potentially magnifying your pain if it's chronic, and with the goal of you being able to better understand that and empower yourself so that the pain may not be as significant to you or as scary or cause as much fear as it potentially could. Just knowing that pain may not be an accurate reflection of tissue damage. So this YouTube video I'm going to show is from TED Talks. If you have ever heard of TED Talks, it's pretty cool, and it's one of the most famous TED Talks in history. It's by a man named Lorimer Moseley. He's Australian, and he spent his life researching pain. He's a neurobiologist, I think is like the umbrella term, but more focused on the neurobiology of pain. So we'll get right into this. I'm going to switch screens here. And he is going to tell you a little story and just give you a perspective on what can be the cause of pain and how magnified it can become. So here we go.
I want to tell you a story.
Let me know if you can hear it or not.
The first 3 years of the neurobiology of pain that you would study at university.
Story and just give you a perspective on what can be the cause of pain and how magnified it can become. So here we go.
I want to tell you a story.
Let me know if you can hear it or not.
The first 3 years of the neurobiology of pain that you would study at university.
Okay, sorry, I'm just told you can't hear the sound, so we're going back, and I figured out why you couldn't hear it, so here we go.
Fantastic. Thanks for having me. No, that's not true. Let me tell you a story. I just want to take that off the screen for the moment. I want to tell you a story that will explain to you the first 3 years of the neurobiology of pain that you would study at university. 8 years ago, I was walking in the bush. I had a sarong on. Very cool. This is what happened. Did you see that? Hang on. This is what happened. Biologically, I'm going to tell you what happened just then. Something touched the outside of my left leg in the skin. That activates receptors on the end of big, fat, myelinated, fast-conducting nerve fibres. and they stream straight up my leg, straight into my spinal cord, up to this part of my brain, and they say, "You've just been touched on the outside of your left leg in the skin." Meanwhile, whatever it was is sufficiently intense to activate free nerve endings. We call them nociceptors. They're thin, unmyelinated, slow-conducting Lada neva. Someone knows what a Lada neva is. Nerve fibres. And that message travels up to my spinal cord, and it gets to my spinal cord, and that's as far as it goes. And it says to a fresh neuron in my spinal cord, you've just been, something dangerous has happened on the outside of your left leg in the skin, mate. And the spinal nociceptor takes that message up to the thalamus, which sits in there somewhere, and says, there's danger on the outside of your left leg in the skin, mate. Now the brain has to evaluate how dangerous this really is. So it looks at everything. And the way that I make sense of this, of what happened to me, is the brain thought, frontal lobe, have we been anywhere like this before? Hang on, I'll just ask the posterior parietal cortex. Have we been in this environment before? Yes, we have. Has it happened at this stage of the gait cycle? Yes, it has. Is it coming from the same location? Yes, it is. What is it? Well, your whole life growing up, you used to scratch your legs on twigs. This is not dangerous. I'm going to give you, the organism, just something so you can kick off the twig and continue on your merry way. And that's what happened for me. I can't show you now, but I took off my sarong, got in the river, got out of the river, and that's the last thing I remember, having been bitten by an eastern brown snake. Survivor. Thank you very much. Now, for some reason, the eastern brown snake works by poisoning you, clearly, and one of the things that it does is activates nerve fibres. So actually, my brain would have got all these messages saying, danger, 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 danger. And in its wisdom, it said, no, 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 no. 6 months later, I'm walking in the bush with a boring talker. You know what a boring talker is? Those people, it doesn't matter what they say, it's boring. That's irrelevant, but we'll call her Naomi, because that is her name. Anyway, this is what happened, right? Yo, wah! And I am in agony. I have got a white hot poke of pain screaming up my leg. I'll tell you biologically what's happened. Something touched the outside of my left leg in the skin. That activates big fat myelinated nerve fibres, which send a message up to here. Just been touched on the outside of your left leg in the skin. It's sufficiently intense to activate these free nerve endings, danger receptors. Take the message to my spinal cord. Just been, something dangerous has happened on the outside of your left leg in the skin. Yes. Well done. You weren't planted. That goes to the thalamus and says the same thing. Something dangerous has just happened on the outside of your left leg in the skin. Nice. So the brain says, thanks very much, thalamus. Kids all right? Good. Anyway. Frontal cortex, anything to tell me about this? Hang on, I'll ask the posterior parietal cortex. Where are we? We're walking in the bush. Oh. You're a bit mate happy. This stage of the gait cycle, where's it coming from? Have we been here before? Oh, yes, we have. Last time we were here, you almost died. I'm going to make this hurt so much that you can do nothing else. And I was in absolute agony for what seemed like minutes, screaming pain, until one of my mates looked at my leg and there's a little scratch from a twig. The pain in those situations was totally different because of meaning. I want to try and convince you that pain is an illusion 100% of the time. Here's a visual illusion. So if you have a look at this picture, you've got a square that's got A in it and a square that's got B in it. Raise your hand if you think that the square with A in it looks darker than the square with B in it. Thank goodness for that. None of you have a really socially embarrassing neurological disorder, except you. That's not true. But watch what happens if we have another look at this. These are those two squares taken out of that picture. And hopefully you can see that. Picture, you've got a square that's got A in it and a square that's got B in it. Raise your hand if you think that the square with A in it looks darker than the square with B in it. Goodness for that. None of you have a really socially embarrassing neurological disorder,
Okay. Let me click this off. All right. So hopefully that functioned all right. I'm still learning this stuff, so thanks for bearing with me. So that was a story that kind of shows that our history. Okay. I think sound is working. Let me know if sound is not working right now. It just demonstrates how your history, your learned behavior can determine your response or your reaction to a stimuli. And so this video goes on. This YouTube video is like 15 minutes long. I just showed you about 4 minutes of it. And Lorimer goes on to say some things, and I took some notes. He goes on to prove to you that there's a lot of illusions. That was a visual illusion that he was about to show you, and several other pain-related illusions. And then his kind of summary at the end is listed here. So when pain persists, he says the brain cells that produce pain, they get better at producing pain. So persistent pain would be chronic pain, right? So they get better at it. They get stronger. They get more sensitive to stimuli. So it takes less of a stimulant or less influence to create the same or potentially even more of a reaction. And another thing that happens is these cells lose their capacity to be specific. So you could imagine is they get kind of desensitized to the location or the specificity. And so when they become less precise, then the pain just gets more generalized and it spreads. And there's actually a name for this in the medical world, in medical terminology. It's called central sensitization. Say that 5 times fast. It's a diagnosis that people can get with when chronic pain persists, and it's really just something that is unchangeable. And so we're going to talk briefly about central sensitization. I just want to educate you about this so that you know it exists. And I'm, again, not trying to minimize the physical nature of pain, where pain is created by what would be called a noxious stimuli, or something that actually causes damage in your body. That still is real, and that does exist. It's just good for us to also be aware of this other side of pain, where stimuli that are not harmful can have the same effect, especially if the pain's been going on for a while. So we're going to switch screens here briefly. I see in the chat that we have Kimberly. Welcome back. Thank you for letting me know about the sound, and Dana as well. Thank you. And Guillermo, good to see you. Glad you made it. Maybe you took the day off work. I don't know. You're over there in New York, I think. So it is work hours. I'm glad to see you here. So, yeah, let me know if anybody else is here. Let me know that you're here. Say hello. Let me know where you're coming from. And feel free to keep posting or post any questions you have. So, switching screens here. Give me a moment. We're going to, let's see, this one. All right. So this is a journal. Last week we got into a lot of research. I'm not going to do that. Last week's topic was imaging, and we kind of showed that imaging is not or damage in the spine is not correlated with pain. People can have tons of damage in the spine and zero pain, and people can have tons of pain and very little damage to the spine. And so so there's a very poor correlation between tissue damage and pain, and that was a very research heavy presentation last week. I'm going to try and stay away from that this week. So let me know if I'm getting too deep into the research, and I will stop. Good to see you, Michael Catan. Thank you. Yeah, I find it very interesting, and I would encourage all of you to go watch the rest of the presentation. You can just search TED Talks pain, and that'll be the first thing that comes up because it's so popular and it's had a lot of views. So if you want to watch the whole thing, it's even more powerful the more you watch it. So real quick, so central sensitization is a generator of pain hypersensitivity, and this is in the brain, basically neuroplasticity. It means changes in the brain. So I'm going to just go to the summary here, and I wanted to emphasize this. It says, because central sensitization results from changes in the properties of neurons in the central nervous system, aka brain, the pain is no longer coupled as acute nociceptive pain is, which is like trauma, like immediate trauma. That would be coupled, but central sensitization is no longer coupled to the presence, intensity, or duration of peripheral stimuli or harmful stimuli. Instead, central sensitization produces pain hypersensitivity by changing the sensory response elicited by normal inputs, including those that usually evoke innocuous, which would be not harmful sensations. And so really what I just imagine in my head is you have these highways or pathways. You can think of them just like highways where pain travels down nerves, and the nerves are the highways, and the pain's traveling down them, and they get so commonly used, so trafficked that they grow bigger. The highways grow larger, and they can hold more painful stimuli going down them, and everything gets emphasized. Thank you for sharing that link, Dana, in the chat. So this is just a little more into central sensitization, and then we will move on right here. So unlike nociceptive pain, which warns of potential damage in response to noxious stimuli, central sensitization creates a situation in which pain is elicited by innocuous or not harmful stimuli. And so these highways just they become the default firing pattern, and they just continue. They persist, just like the pain. They continue to be the normal pathway of sensation. It's instead of a side road that you can take when necessary, it's the normal pathway, and so we're always feeling it. This change is protective because it helps healing by limiting use of an injured body part until the injury is fully repaired. So that's the body's intention, and so what we end up doing is we limit the use of our back, of our spine, and it's right in the middle of our body, so we limit activity. And so this is not a good thing for chronic back pain, and it's part of the cycle. We feel the pain, we limit use, and that causes the problem to get worse. And so as with someone with chronic lower back pain or chronic pain of many types needs to learn to continue to use their body despite the persistence of the pain, because you've now learned that the pain is not an accurate reflection, that damage is still happening. And so we'll get a little further into this, reading the red now. Central sensitization becomes pathological if inflammation persists. Something like rheumatoid arthritis is a really good example of this, in which no healing is occurring, but the pain continues. And so this is just a bunch of big words to say that there's no more stimulation, but the pain continues. Central sensitization represents not only a state in which pain can be triggered by less intense inputs, but in which the central sensitization itself can be maintained by a lower level or even a different kind of input. It could be something as simple as being late for work that can trigger the pain in the back because it's become so sensitive that very little stimuli can trigger it. So done with the research. There's one other thing that this is not research, but this is just a website I found, and I thought that I read the whole page. I thought it was very helpful. And so this is like, how do we address this? What do we do about this? And so I thought it was kind of practical to share. So interventions aimed at enabling patients to break out of this loop that they're calling it and change their perception of pain may be more effective than interventions that appear to endorse the patient's view that the pain is a result of a problem and that it needs to be solved with pain relief. So we get ahead of the pain, we get above the pain, upstream of it, and we know why it's happening. We know that it doesn't make sense at a certain point, and so that itself, that knowledge, as I continue reading, you'll see can have a really big effect. So psychotherapy, for example, can produce long-term changes in behavior through learning, which generates changes in gene expression that alter the anatomical pattern of interconnections between nerve cells of the brain. So basically what that means is learning changes the brain. And just learning stuff like this can change your pain pathways. It can have a really powerful impact, more effective than traditional pain management, where you go see a doctor that's going to just treat the pain for the end result that it is. When we treat it with our mind, it can be more effective. So the regulation of gene expression by psychosocial factors makes all bodily functions, including the brain, susceptible to psychosocial influences. So that's it on research. I did not want to spend too much time with this, but hopefully that was helpful to someone. If I can help one person, then I've done my job today. Let's go back to this screen. We're going here. All right. So, yes, John Sarno, Michael Catan. I just shared my book list in the program. I'm not sure if you're in the program or not, but I had a discussion with a student in the program, and that book came up. And that book, the one is Healing Back Pain, The Mind-Body Connection by John Sarno. Was a pivotal moment in my life. It wasn't the complete solution to my problem. There were also physical components, as there typically are with back pain, but it had a pivotal effect on my life with just the pain itself. And so, yeah, I'm glad that you're aware of that book. I was going to spend a lot of time talking about that book on this stream, but I just highly recommend everyone read that book. So some conclusions from Lorimer Moseley, the research, and just what we've learned is that pain, especially chronic pain, is no longer helpful. It's not accurate. It's not informative. It just becomes a pattern of behavior. And there is definitely an element that may have originally caused the pain that still exists, but we can no longer trust the pain itself if it's been going on for a long time. It's likely heightened, and it's likely spread, and it's likely highly sensitive, because that's what happens with nerve cells. They can become more sensitive. So chronic pain does not accurately reflect tissue damage. You can have pain, you can be sitting there in pain right now and have no damage happening to your body. That's what that means. And that's actually what we found last week too with the imaging, with the people who have lots of pain and little to no damage, and the people on the other end of the spectrum who have lots of damage in their spine and no pain. And so we just taking this into account, that there may be an illusion happening, and this illusion is trying to protect you from something, but that thing that may not need protection. Learning this can have a positive impact on your relationship with your body and with the pain. And all that said, pain is still very real. We feel it. It's the end result of all these processes, even if the processes are related to our past experiences or our childhood or heightened sensations, heightened, more sensitive nerves. It's still very real. But I encourage you to empower yourself. The act of learning this stuff, the knowledge that you are gaining by attending this stream or doing whatever else, reading the book by Dr. John Sarno, it can change your brain, and it can make your pain less scary. It can give your pain less power. And what that can do is it can give you more power over your own body and your life, knowing that you're not hurting yourself, you're not causing damage just because the pain is there. That's a lot less scary to me. I don't know about you. So that is the extent of the presentation, and so we're going to get into some questions. If anybody has anything they want to share about experiences they've had, any experiences you've had with pain, or just anything you want to share at all, feel free to share, and we can talk about that. This can be a bit of a discussion, or if you have any questions, I'd be happy to answer them. I'm going to get into some questions that we've had from core balance training students lately this week. And so we've had several questions that were very similar. And so I'm going to address those on this stream now. And I'll be keeping an eye on the chat too if anybody wants to add anything. So I'm not going to start with this one. Start with this one. So I've had a lot of questions kind of oddly about hamstrings in the past week or two. It's not something that always happens, but getting questions about hamstring cramping doesn't always happen, but it seemed to all come at the same time. So we're going to talk about hamstring cramping. May not be relevant to everyone, but if you're in the program, it's probably something you've experienced when doing the bridge. And so I'm not going to read all these questions, but basically everyone in this post is saying, I'm having cramping while doing the bridge, and is that okay? And should I do something differently? And actually, one of the people, Bill, who posted this, I think this morning or yesterday, is in day one getting hamstring cramping. So I'm just going to give kind of an umbrella answer that hamstring cramping is okay. It's expected and normal when doing the bridge in the beginning, because the hamstrings, without getting too deep into the anatomy, the hamstrings are in a very shortened position in the bridge. You have your knees bent pretty far and you have your hips extended, which puts the hamstrings kind of at a mechanical disadvantage. And it's a very vulnerable position for them. They typically don't exercise in that position. If you can imagine, the bridge position is not a common position for strength training or exercise. And so when muscles feel vulnerable and they don't feel safe, oftentimes what they do is tighten up or cramp up. And so it's just kind of like a reaction. It's a protective mechanism. And that actually tends to go away pretty quickly if you continue practicing and doing the bridge, because they get stronger. They get more comfortable in that unusually shortened position. And it could only take like 2 sessions or maybe a couple days, maybe a few days at the most for the cramping to go away. So my advice for everyone is just to stick with it. Don't be scared of the cramping. And if in one case, one of the very top question, she didn't say cramping. D says spasms. I'm not 100% sure if this refers to cramping, if it's spasms, because spasm could be referring to like a more of a neurological thing. And so I just wanted to clarify with you, D. I don't know if you're here, but if you're watching the replay, that if it's not cramping, if what you're experiencing is not cramping and it's spasms from like a nerve impingement, then my answer would be different to you. So you can clarify that with me and let me know, is it cramping or is it spasms? I just kind of assume it's cramping because it's doing the bridge and it's obviously a very common thing. So anyway, yeah, the cramping goes away pretty fast, pretty magically, and it's nothing to be worried about. Michael, I see that you said you're in the program. That's great. Sounds like you're doing pretty well. Oh yeah, okay. Of course. I mean, there's not a lot of action in the chat today, so I can definitely talk about cycling. I'll actually reward you for asking it, and we'll go to that right now. And this next question will be about driving. So the topic is transportation. Let me just read your question a little bit more thoroughly. So you're an avid cyclist. You love road cycling. Any tips for what you should be conscious of? Yeah, cycling is... All right, week 6. I do recall your name, actually. I remember you've been in the program for a bit. All right, great to hear you're sticking with it too, Michael. So, cycling is repetitive, and it's also in a very closed down posture, very almost like the fetal position, right? If you took someone in the cycling posture and you laid them down sideways on a bed, it's pretty close to the fetal position, which is the pattern of posture that we are trying to reverse. And so my advice to someone who spends a lot of time on a bicycle is to counterbalance those effects, because you're exercising your body, you're training your body in this closed down position. So we want to do what some people call cross training to open it back up. And the bridge is the perfect thing for that, right? So cycling, closed down hips, bridge, open up hips. So I would recommend doing that after cycling. And then during cycling, you can, I call it core, whatever I'm doing, I call it core fill in the blank. So core cycling would be just in your mind, thinking about the movement that you're doing originating from your core. And so with cycling, the pedaling motion, that the initiation of that motion starts in the core. It's your powerhouse. And so trying to shift your center of energy into your core, and then the legs are more of a peripheral activity rather than the main focus. And so you can get a lot, it's really effective. I do it with riding a bike as well. It just gets that core a little more engaged, and it can be less focus on the quads and the hamstrings. So I would say try that. I wouldn't suggest too many different things, because that's a lot to focus on just right there. Let's see. I'm going to read your notes you just posted. So after 45 minutes of a hard ride, you get low back cramp. Okay. Oh, yeah, you do. Okay. Okay. Yeah. Okay. Okay. I gotcha. So it sounds like you fit the bill exactly. So it's the tight hip flexors that are bothering you. Standing up on the bike is the relief. And so if you could figure out a way, and I know there's, positional stuff like raising your seat, and you can get the handlebars better. And so I'm sure you're aware of that stuff since you're avid, but I would be, I'm going to focus more on how you're using your body. And if you can get yourself to shift, there's a shift that takes place. If you can harness this intention where the main focus, the main muscle group that you're using shifts into the core, it can have a pretty powerful effect on letting the other muscles that may have been the main focus in the past just kind of let off a tiny bit. And over thousands of cycles, thousands of pedals, that can have a pretty large impact. So I'm going to stick with what I said. It sounds like the hip flexors are the problem. I would be maybe doing the bridge before your ride as well to open those up, because the bridge, what it does is it lengthens the hip flexors with a long-term effect. Like it will last through your ride. And I'm guessing you have clip-on pedals. And that's if you're pulling up with your thighs, pulling up on the clip-ons, that's hip flexors. So you're going to want to definitely have your core engaged to protect your spine. It's the same motion as the dying bug. You've been through that. The back anchor challenge is week 4, module 4. So it's that same motion where you're staying connected to your back anchor. And this is true for everything. So if you're listening and you're not a cyclist and you don't ride bikes, it can be applied to any activity. I do it with paddling on a surfboard. I call it core paddling. It's my arms doing the motions, but the origination of my movement is in my core, and it has a really powerful effect. So maybe pull up a little less on those clip-ons, Mike, and do more pushing. Remember the push away concept. It's really powerful. So I would shift to doing if you can. And I know if you're like in races and stuff, I don't want to be messing with your time, but the pushing is a healthier motion than pulling or lifting, pushing away. And even if you are lifting, think about it from a push away perspective. Thank you for all the conversation in the chat. It helps me and helps me help you. So we've got and let me know if you have any more questions, Mike. I'll keep going with you, but I'm going to get to this next question. We'll try to be wrapping up in the next 10 minutes here. So this question is from Michelle. This came through, I believe, yesterday. Her biggest pain trigger is the car, and she wanted to know if I have any suggestions for the best way to sit while driving. What should she be doing with the core when she's in the car? So I've had this question from other students as well. I've typed out big, long answers, and so I figured this time I will just answer on video. I'm going to go ahead and switch to this one because it will just help with me demonstrating. So we're going to pretend we're in a car here, bouncing around, right? All right. So the position of a car is not ideal, and that's not much we can do about. The best thing you can do is get yourself a bike, Michelle, if we're talking about cycling, right? But if you can't get yourself a bike, and even an electric bike, which is happening a lot in this town, in the town I live in, Santa Barbara, people are replacing their cars. I have several friends that have done it with electric bikes, and now they travel to work or school or wherever on their bike because it's awesome for many reasons. But if that's not possible for you, you got to stay with the car. Then we got to make it as ideal as possible. And so the reason a car position is not good is because your butt is so low and your knees are lifted up and your legs are out in front of you, so you're not really using your legs at all in sitting. It's just like all 100% of your body weight just right on your butt and right on your spine, really. And so the way to balance that out would be to scoot your seat back as far as possible. So this is more ergonomics, and then we'll get into the second part of your question is what to do with your core. So scoot your seat back as far as possible. Actually, we're going to tilt your seat back as vertical as possible, and that's not so much for your lower back, but it's for your neck and your upper back, because I'm going to turn sideways here. If your seat back is reclined, and then you don't want to look up at the sky while you're driving, you have to look at this road, so you go like this. And what that does, I can't really get much of a good angle here, but it causes really poor rounded shoulders, forward head posture. And so by bringing the seat from reclined like this to vertical, we can have a much better posture for our upper back and our neck. And since the back and neck are connected with the lower back, then it probably has a positive impact on the lower back as well. So we've got the seat back as far as possible. We've got the backrest as vertical as possible. And then if you do have a setting for elevating the seat, then I would recommend, I drive a minivan, and so they have all the cool amenities in minivans, so I can actually raise my seat up a little bit, and so I do that. So that's another, for some people, another option. All right, so that's positioning. And so what to do with your core. This is something I've been doing for a while. I think it's pretty effective, and it's a little trick to get to kind of activate the core very subtly. Like we're talking 2%. Remember, I'm all about subtle, and that's because the stuff we're learning, you need to be able to do all day long. And if you go high intensity, not only does it use the wrong muscles and contributes to the problem, but it's not sustainable. You can't do it all day long. And driving, if you're on a long drive, I'm not going to be suggesting doing like abdominal contractions for a 2-hour drive, right? So very, very subtle. And if you got your hands on the wheel, right there. Oh, I don't know why it's kind of awkward here. So I'm underneath the wheel, and I'm gonna just be gently pulling on it. And I wish I could. Oh, I can get a little lower here. Okay, so gently pulling on the wheel, like a very gentle 1 pound of pressure pull towards me, and that pull can have a bit of an activation on the core muscles, and so and it can give you just a little gives you a little bit of a tactile cue, or just some feedback, some tactile feedback that can allow you to better connect with your back anchor, very subtly, very gently, to the back of the chair, depending on the type of chair or backrest you have. And then the other thing would be the breathing. So there are things you can do. At the end of the day, driving is not ideal, especially if you, the gas, if you have a problem, a left to right imbalance, using that right leg, always the hip flexor being active on the gas and the brake, is another thing. It's just not very ideal. And so if you're on a highway, a long drive, if it's not raining, then I would suggest using the cruise control whenever you can. And just be safe with it. You're not supposed to use it when it's raining, right? People don't know that in California because it doesn't rain here, or Southern California. But I'm sure if you live somewhere where it rains, people already know that. So yeah, that's it. Gentle core activation with a slight pull on the wheel. And that can help you just connect to your back anchor, and then breathing into the back, sending the breath down. The lower you can send it. So in the first lesson of the program, we teach sending the breath into the lower back, but you can actually get a lot of decompression by sending the breath down into the pelvis. And so that's more of it's more of a vertical reaction than the expansion in the lower back, and that can help with driving. Take frequent breaks, and then if you can, I can't be recommending stuff like this, but I'll just say that I've done this on long drives. Like you can do the figure 4 stretch where you get one ankle over the knee and just do like different movements, the variety. The body loves variety. The body loves movement. So figure 4 stretch over the knee, and get creative with some other movements you can do as well. Hopefully that helps. We'll get on to the next. Michael, I see you have a question in the chat. Does sleeping position matter? Yes, it matters. Is it something I'm going to recommend? I try to avoid it because sleeping is very personal, and I wouldn't want to recommend something and it have a negative impact on somebody's ability to sleep. So, yes, I would say just do what feels best for you. If I said, like, in a perfect world, what is the best sleeping position? is probably on the back on a firm mattress. But I don't do that because I try to, but I don't all the time because I tend to like sleeping on my side. Side sleeping is a little more comfortable on a softer mattress because of your shoulders. And sleeping prone on the belly is probably pretty cool for the lower back, but not so cool for the neck. So there's no clear, obvious answer. If you can sleep on your back and you have a firm mattress, then you're probably winning. But if you have a soft mattress, I don't think sleeping on your back is ideal. If you think about where we came from in a long, long time ago before mattresses, we probably slept on a firm surface, and because of that, we probably more often slept on our back. So mimicking what we did for hundreds of thousands of years is probably the most natural. Guillermo, we've got a follow-up question on driving. We've got, while in the car as a passenger or driver, is doing any back anchor recommended? Yeah, so that's what I was talking about with the just the gentle pull on the driver's wheel that can help you to connect to your back anchor. It just provides like a little change. I find that trying to connect your back anchor while driving without giving a little pull on the wheel, it's just hard to get that feedback. And so adding that little gentle, like, I don't know, it's just like a gentle, I barely call it anything. It's just it's a little feedback from the steering wheel, can allow you to connect to your back anchor. So yes, I think that's great, but very subtle, 2%, 2 to 5%. And breathing you can be working on all day long, and I don't have a problem with any, the amount of time that you spend working on that, or even the intensity. Okay. Next question. These are older questions that I didn't get to last week, and I did answer them in the lessons. I typed the answers, so I'm not going to get to those today. I think it seems like we're going to wrap things up right on time today, 1 hour. So that's cool. That'll be like my first time finishing on time. This is, I didn't realize I'm on this screen still. Here we go. So here's my conclusion. We've already looked at this slide, but to me, it's the most important thing is just to be aware that pain is not, when it's chronic, when it's persistent, it's not trustworthy anymore. It may not be a reflection of damage or harm or danger to the body anymore. It, in many cases, very commonly, may be just heightened sensitivity of nerves due to prolonged pathways, firing patterns of nerves that it's been going on so long it became the default sensation that you feel all the time or nearly all the time, because that's the way that the electricity fires through your body. And so it's up to you to determine that. There are certain types of pain, like sharp pain, and certain neurological type pain, like sciatica, that can be reflective of a physical thing, a nerve being impinged. So that's for you, or if you're with your doctor, you can talk to him about it. That's for you to decide. But if you feel intuitively like your pain could just be something that's been going on for 5 years, or not even, doesn't have to be that long, and it's just kind of spread out and just very persistent, then I would consider this idea that we know from the research now that it might not be a reflection of any damage to your body, and that is less scary. The pain is less power when it's not hurting you from a structural perspective. So that's what I'll leave you with. Kimberly, you're very welcome. Michael, the weakness is not an illusion. Yeah, numbness and weakness together is not an illusion. I believe that is a nerve being pressed on, compressed, or impinged. I would reflect on when that happens. After what? What did you do before that happened? Maybe in the hours before. And I would reflect on that, and then I would try to learn from that and avoid those triggers that cause the weakness, because that's real. And that's a reflection of a physical thing happening in your body, especially if it's temporary. What the focus of today's presentation was persistent pain, and that's what can become heightened through simply increased sensitivity, and so again, that's called central sensitization, and it's a real thing. It's a real diagnosis. You can look it up. I believe personally that it's a lot more common than what is reflected in the number of people who have it. I think it's extremely common in the back pain population. So I hope this information helps you, and let me know in anywhere if you're in the program. Post in the lessons, post in the chat, and give me feedback on this stuff if it's helpful, or if you have recommendations. Gladly welcome constructive feedback. So super grateful that you're all here. Thank you for showing up for yourself. And until next time, get down on the floor and give some love to your body that does so much for you. Take care.